Oh, hey, Chris.
Hey Chuck, how are you?
Fantastic. It's early on a Saturday morning, hanging out with you. What could be better?
Now, I've been told that our energy has been good on a couple of, well, at least the most recent episode, and we were recording on a weeknight. So hopefully we can capture some of that end of day weeknight energy on a Saturday morning.
Yeah, it we can talk a little about we were together last night. It was super fun. And then my wife's out of town. When my wife's out of town, for some reason, I don't like consciously say I'm going to stay up and wait till my daughters are 20 and 22. I'm not going to consciously stay up and wait for them to come home, but it just happens.
Uh-huh.
When my wife's here, I sleep like a baby. And so I had a late night.
Well, that I guess that means two late nights in a row. Didn't you have a special dinner on Thursday as well?
We did. I had a big birthday, the double nickel birthday, which was great. And my wife is out of town. And so my daughters suggested I take them out to dinner to celebrate my birthday, which we went to a great restaurant here in St. Louis that you love as well. And it was a really fun time.
Funny, you mentioned the double nickels, which for the uninitiated is 55. And I thought about where I would be and where our family would be in 13 years, and it got me a little gave me some palpitations just thinking about what that's going to be like.
How old will your kids be in 13 years?
23 and 20, so not that dissimilar from where you are right now.
Yeah, I have one older who's about 26, but yeah, and look, every life stage is great. I'm enjoying this one very much. I don't feel old, although my body tells me I'm old.
A little more stretching, perhaps. We
Yeah.
we bid farewell to our outgoing fellows last night. They still have about 5 more days of work to do, but we had our nice graduation dinner. It was a really nice moment to wish Nick, Dan, and Eric off to their next stage in their careers.
Yeah, you organized a really nice evening. Super fun to get together. Most of the spouses were there, with a couple of with the exceptions being our own, you and you and me.
They had other priorities.
And it was really nice. And I have to say, the fellows gave us a nice gift. I had talked to Dan a couple of months ago, and I definitely didn't bring it up, so he must have brought it up. And I'm like, yeah, there have been some very memorable gifts from the fellows to the attendings. And I will say those are very much appreciated. And we're not looking for a big spend, just a little thoughtful gift. It's just really nice.
Yes, there have been some very thoughtful gifts. This was one of them. We will not be sharing the gift online for so many reasons, but it made all of us laugh. It clearly will remember that class very well for so many reasons, including the gift.
We will. We will. Great, great class.
I don't
I
know. I met with our new fellows yesterday. I can't see any of them angling for podcast mentions, but you never know. There might be some dark horses, so we'll see.
We'll see. We'll see if they mention this mention.
Well, we have a couple of things to do today. I want to ask you a couple of questions. We're going to talk about an interesting case. Remember, we're supposed to talk about what we're going to talk about from the jump,
Oh, I
uh,
forgot
and then
already.
and then we will go into some tips and tricks for entering practice, which is actually a topic that Dan Hong, one of our outgoing fellows, and his colleagues Eric and Nick selected for conference on Monday morning. But because I am missing conference, I thought this would be a good opportunity to go through that and get some of at least my thoughts on the record for them.
Yeah, we will. I wanted to share with you, and I think some of the listeners will be interested. Despite being double nickels old, I am very interested in artificial intelligence. We have had Alpesh Patel on the show from Northwestern, and Alpesh and I have talked, and we should bring him back. We've established a small committee in the department, both to consider AI agents to help with our processes, whether that's in clinic or on the back end with revenue cycle management. I've been interviewing a lot of companies, and I think there's some real amazing things out there. But also, the role of the committee, as we see it, will be to help each of our partners understand what they're missing. Because my experience has been, if you're not daily on a daily basis interacting with AI and trying to get a sense of it, then A, you're missing the boat, and B, you won't ever truly adopt it. And so it's really been a fascinating process for me. You're much younger, I'm sure much more adept. So I'm curious as to how you engage today.
So interestingly enough, I'm not terribly engaged with it. I can be adept, but I know I need to. There's some really interesting stuff that I think that could help me on a daily basis, just in the realm of medicine. Things like open evidence, I think, are great. But unlike you, I don't have any AI programs or apps installed on my phone. I probably should. I still search the old-fashioned way, which is, maybe I'm an old soul. I don't know.
Good for the environment. Um, Yeah, I will also add one other thing before I want to hear about your case. Um, I was a friend, I'll leave it at that, said to me, when I listen to the podcast, Chris sounds so much better than you. And I'm like, you mean what he says? I don't know. They're like, no, 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 no. How his voice comes across. And so then I'm like, okay. And I have this great microphone and headphones, and they've been sitting in the basement. So we'll see if the listeners can tell a difference. I would love to know, reach out to us because this is, I'm engaging at a higher level with microphone and headphones, and hopefully it sounds better.
Okay, great. Well, I mean, we've been relatively Spartan in terms of the tech, for in terms of using Zoom, and it's worked out so far. But I always tend to have the glitchy internet, and you have the home court advantage of being the one with the recording. So I'm glad at least somebody thinks I'm sounding okay from an audio perspective. So thank you to your friend for pointing that out.
Yes, absolutely. Would maybe before the case, we'll do one more thing. The Upper Hand is sponsored by PracticeLink.com, the most widely used physician job search and career advancement resource. And from memory,
Becoming a physician is hard. Finding a job doesn't have to be. Join PracticeLink for free today at www.practicelink.com/the upper hand.
love it. You are so talented.
Hey, you know what? We did a little light roasting of the fellows. I did a little light roasting of the fellows last night. Usually the intro that I give is a little schmaltzy, but I figured this was a class to go after a little bit. But it was very I felt very uncomfortable. I was like, I'm usually not trying to be funny, so it was a bit out of my element. I was more nervous about that than talking in front of the Hand Society.
Well, it's funny you say that. I think that's right. I think it's all about what you're trying to say and your comfort level with saying it. I found it very funny, memorable lines, all appropriate, a little direct, but taken
A
the
little
way it
too on
should.
the nose.
Well, maybe that was it on the nose. It was great. I struggled with my toast slash roast of Eric because my interactions with Eric have been all business. He's an amazing fellow, and I haven't seen some of the things that you have seen that are humorous. And so my toast was
I had to
nothing
work for
special.
those, Chuck. That didn't come easy. I was fortunate to have a second rotation where I really got to needle him a bit. And get to know him much better. So again, as I've told everybody, I customize the educational experience per fellow, per resident, so everybody gets a little bit of a different bag. And Dan noted that it must be interesting for Hannah, my athletic trainer, to see all the different phases and ways in which I motivate. But anyway, interesting case that I wanted to discuss. For purposes of privacy, we'll say this is a person in their double nickel type era, perhaps plus minus a few years, but had a very bad slip and fall and fell down the stairs and injured their shoulder and had to have shoulder surgery, and open shoulder surgery, and had a block. Now, at the first post-op visit, it was noted that he had difficulty flexing the IP joint of his thumb and the DIP joint of his index finger. So this is at the first post-op visit. No neurologic peripheral nerve history, no spine history, uncomplicated surgery by way of the surgery that was done. But this palsy was noted at the first post-op visit and just persisted for 3 months, um, except that the index finger started to flex better. Watched for longer. And now this patient, say a partner refers this patient to you at 6 months. What's your thinking? Are you hoping they already had a nerve study? Would a nerve study change what you're going to do? Have you seen this before?
So, so it's a big topic, actually. It's super interesting to me. First, thinking about our anesthesia colleagues and the blocks they provide. We are so fortunate. We have a really talented group of anesthesiologists, and I've watched it evolve from all proximal blocks, where it started with axillaries, and then now they're supraclavicular, But more and more with my hand-based surgery, we're getting ultrasound guided forearm level blocks. If it's just a couple of nerves, if it ends up being, all the nerves, then they do something more proximal. And those forearm level blocks are great, and they, don't paralyze the shoulder and the elbow, so patients are happier. What we don't talk about, and truly, I don't think we know the incidence. There are a handful of patients each year that have some type of residual from the block. I've seen CRPS, I've seen nerve palsies, and it's hard. And I'm not pointing a finger at anesthesia, but you and I end up mostly, addressing those and dealing with the consequences. Some of our anesthesia colleagues are very eager to see those patients back, and some just want to keep doing, taking care of patients. So I'll start with that. What do you think to what I said?
Yeah, it's hard because I mean, so we've got an AIN palsy in a setting of an open shoulder surgery and a block, which was in this case was done at the scalene level. So it's interesting because sensation wise, not a full median nerve palsy. The rest of the lateral cord is working. So it's interesting. The AIN is just tends to be one of those nerves that gets involved in things like this. Now, I think the other thing in my differential is this like a weird viral neuritis, Parsonage-Turner kind of situation. Patient denies having like a painful prodrome, doesn't have any changes in medications, no vaccinations, no other recent, viral illnesses. So I'm thinking it's either related to the surgery or the block. And patient asks me, what do you say? I mean, I tell them, I don't know. I don't think we'll ever know. I don't think and I try to say this in a nice way, but like, there's not really a point in trying to figure it out. I'm meeting you now. I want to take care of you now. Here are the options we have.
Yeah, all well said. And I completely agree. And it always does come down to what you mentioned. Is this an iatrogenic injury related to the surgery for over-retraction or whatever it may be? Is it related to the block? And obviously, sometimes we know it's one or more likely the other. And sometimes in this situation, we don't know. And hopefully the frustrated patient, because the patient should be frustrated, is not trying to point fingers or anything further than that. But
He's just trying to bend his thumb, Chuck. He
yeah,
doesn't want to point fingers.
yeah. Oh, I see what you did
Heyo,
there.
heyo.
Anyways, yeah, it's a really interesting problem that I'm sure all the listeners have experienced. I don't have any sage wisdom other than honesty and admitting that we often don't know the ultimate, proximate cause of this.
So, say, would you want a nerve study at 6 months, or would you say it doesn't change what we're going to do? Say, no clinical evidence of thumb IP flexion.
Well, I mean, if this is you tell me, you're the nerve guru, but at 6 months, there is absolutely a chance that this will recover, given the level of the injury was shoulder level. So while we know the issue, we know the options for treatment, I probably would consider it. Did you?
Patient came with one. So that helps just in terms of not having to make that decision. There was in the FPL, there were fibs and sharp waves, which indicate active denervation in more recent process, but no motor units detectable, which matches a clinical exam. It's interesting. In this particular case, I try to tell them, the classic teaching for this is to wait, because this might come back 18 months later. That's kind of hard for people nowadays. In this particular patient, so some would say, well, why do you even need, thumb IP flexion? This particular patient, because of his occupation, needed it and wanted it sooner rather than later. So, I'm in a quandary where I'm telling him, look, we absolutely, nobody, quote, as Marty would say, nobody, need to have surgery. It's not cancer. It's not heart disease. It might be reasonable to consider, but then what surgery do you consider? So classic teaching would say, wait. Absolutely gave the patient that option. He opted not for that. I gave him the option of a tendon transfer. And I said, we can do this now. We can do this 6 months, 9 months, whenever works for you. And you have the time to get over it. And then, the more interesting recent options would be something as interesting as like a neurolysis, a microneurolysis, getting, the team at HSS has great MRIs or high resolution ultrasound that can help you better understand the lesion, look for little torsions, things that you could release. And then there's always the option of a nerve transfer, and whether that's a supercharger or an end to end. So you can get into this whole decision making process for a nerve. As much as I like doing nerve, patients still has to wait a long time after that to get the result. And I'm not sure. I mean, I don't know in your practice, your results with a tendon transfer for restoring FPL function? Has that been something that has been particularly gratifying, and what kind of results have you seen?
To address your first kind of comment, I think it's really interesting that patience with a, not patience, not patients, but patience
The
or
virtue.
the virtue is not just disappearing from medical care. It's just in society. We are not, maybe I'm just speaking of citizens of the United States of
Chuck, you
America.
can get McDonald's delivered to your door. Like, you
Yeah.
get anything delivered to your door, but like crazy. Like, you should just go to McDonald's and I just get it delivered to you.
Delayed gratification is not part of the lexicon. And I am, from my kids' perspective, they understand that I am a big believer in delayed gratification in many domains in life, but our patients don't want to be patient. And it's a really interesting topic. I understand it, especially if it strongly affects your daily life. I'm fascinated by some of the microneurolyses and the advances in imaging. For me, this would be a tendon transfer or it would be a referral to you. I think tendon transfers provide a very reliable, very good result. And getting the balance right is tricky, but I think just because none of us do it that often, but I think it's a good surgery.
So for you, is this say we so this patient, because I kind of steered them because I think that as much as I like doing nerve surgery, I think the tendon transfer in this particular case for this particular patient, their timeline made more sense. Are you doing an end-to-end tendon transfer or sewing into the side of the FPL tendon?
Yeah, it's a good question. And you and I have written a little bit about this in regard to FPL rupture after volar plating of the distal radius. In this case, I think I'm doing an end to side. In other words, not cutting the FPL, but rather just adding a motor strength function. And I'm curious to learn which one you favored, like which technique and which muscle.
Well, I mean, I think this patient particularly wanted strength with thumb IP flexion for their job. And I do think that the FPL eventually is going to come back. I have every reason to believe it. So for that reason, although the downside is that you have a slightly altered vector line of pull, I went end to side. And I like the BR for this, and also FPL is a huge muscle belly. And Marty likes to talk about that too. So I don't like, sacrificing that. BR doesn't have a ton of excursion, but we got a pretty nice length on it, nice dissection, and sewed into the side of the FPL, kind of right at the almost where you would do an approach for a distal radius fracture. How do you like to tension these?
Yeah. Well, I guess there's two questions. One, how did you do the repair? Not an anastomosis, but the repair and
The
it's
tenorrhaphy, so to say?
nicely well played. Yeah, I mean this. I think with the BR, it can be hard sometimes to do a pulver Taft weave, and so maybe trying to get a weave or two rather than the classic three. For me, I do use the wrist tenodesis to help me. So with wrist extension, I want a strong IP flexion moment. And with wrist flexion, it doesn't have to be hyper extended, but I'd like to see the thumb extended. So a little overly tight, but I use wrist tenodesis to judge that. But tell me more. Tell me how you did it,
So for those of you who aren't watching on YouTube, you saw a great
which
demonstration
you
of
should be.
tenodesis. So please check it out on YouTube. Subscribe on YouTube. I'm sure there'll be some kind of bonus if you subscribe on YouTube. I don't know. I don't know what we're gonna do, but you just have great videos of Chuck. So I think this is interesting. So for me, I did this. I didn't want to make it too tight, but I put the wrist in neutral and I held the wrist in neutral, and then I flexed the thumb IP joint passively. While our fellow Eric did a great job with the tenorrhaphy, and I did a pulver Taft weave. I got two weaves, and then I laid the rest of it side to side, the rest of the tail. I know that there's a lot of work from Jan Frieden's group showing that their side to side technique is strong, just as strong, if not stronger, and less bulky, which is nice. And then after that, we checked tenodesis, exactly how you described it. So, and then post-op wise, I put them in four base dorsal block splint for the thumb, just to keep the thumb in a slightly flexed position. But then after that, hopefully start things moving within a couple of weeks and eventually strengthening.
I love it. I think that sounds like a well done surgery. Before we move on, anything else that we should hit on this case?
How strong do you think they get? And do you think they, intentionally, like you mentioned, I to sew them in a little bit tight and in a little bit of a flex position. Do you ever think they miss the thumbs up hitchhiker position, or do they get that back?
Obviously, it depends a little bit on how you tension, and BR, is, as you said, limited excursion. It seems to work well in the tetraplegia population, not that that's a population I treat. I think they get extension, but not true hyperextension. It may affect their retropulsion ability of the thumb. So I think it is the motion of the thumb can be really, really good, but it will not be perfect.
Right. And I think that's an important counseling bit, both for this particular case as well as if you're doing an FPL reconstruction for whatever reason or a tendon transfer. So before we move on to some interesting questions from our fellows, we should acknowledge and thank our sponsor. So join our sponsor, Checkpoint Surgical, at the ASSH annual meeting for their industry forum, Controversies in Hand and Nerve Surgery, a high impact session that dives into the latest breakthroughs in clinical debates shaping the future of nerve and soft tissue management.
Oh, I like that. They threw in soft tissue management, led by experts Dr. Michael Hausman, Dr. Karen Desai, and Dr. Ketan Sharma. I apologize if I didn't pronounce those correctly. This session explores cutting edge topics like the use of a dehydrated amnion chorion membrane in revision surgery, scapular malposition's hidden role in thoracic outlet, and subacromial impingement. Wow. And how intraoperative nerve stimulation could help predict surgical outcomes. This session takes place Thursday, October 9th at 11:30 a.m. Mark your calendars, Dr. D.
Chuck, when was the last time you thought about the scapula and subacromial impingement?
Well, not often, but I do think about the kinetic chain, Dr. D. Don't underestimate my treating the whole
There you
patient.
go. There you go. I have a love-hate relationship with thoracic outlet. We're currently in an okay place, but we'll see how that goes.
It's yeah, it is in your world. It's not really in my world. I've had a couple of interactions where patients have flown all over the country, and what's fascinating to me is some have chosen to come back, or I've talked to them on the phone, and for thoracic outlet, they get very, very different advice. You must do a surgery. It should be arthroscopic. It should be open. You should do this. You should do that. You should do nothing. Fascinating stuff.
I I continue to see patients with thoracic outlet syndrome, partially because the patients or the docs who refer me, those patients also refer me other things that are of interest to me, just from a practical perspective, which actually touches on some of the stuff that the fellows wanted us to talk about. Also, it's a to provide a variety of opinions to the other folks that they may see in the St. Louis area. So I do it. I think it's kind of like a duty I feel, just because I do treat things a little bit differently than others, because there's no one right way to treat this condition. Obviously, it's very patient dependent.
Okay. Well,
Try
thank
to be
you.
as diplomatic as possible there.
You are very diplomatic. Thank you. I'll say thank you for your service. Um,
Yes, yes. So I
all
wanted
right.
to launch into this. So Dan, Nick, and Eric put together a list of questions that they wanted the faculty to discuss at conference. I think scheduling pearls is probably a good place to start. So if you're starting as a surgeon going into practice, a hand surgeon, one of the questions they thought was time slot. Questions they had was time slot lengths for new established patients in early practice. That's one. Structuring of split OR and clinic days. Should you do clinic in the morning, followed by the OR, or vice versa? And then how do you structure your quote free time in early practice before your patient volume increases?
Well, let's take the last one first. Free time early in practice is something that you and I would kill for. There's so much we could do with it. I would say young surgeons, young therapists should enjoy that time, but make use of that time. And in an academic setting, I would encourage thinking about research, continuing to read and prepare yourself. I mean, that's the big opportunity is instead of doing that at night before a case, do it during the day. And there's just so much learning. But also, get home at a reasonable hour and enjoy yourself. I think that free time is gold. You don't want it when you're starting in practice, but you should take advantage of it.
Yeah, no, I agree with the prep work. I read for every case, including a carpal tunnel, for at least a few years of practice. Things have changed a bit since then. as I become more comfortable. But I think that's really important. I used to prep my clinic the day before. I would look through every chart, try to pull off all of the medical records and make a little summary for myself, which made the actual process of seeing patients a lot easier. Now, if I tried to do that for my current clinics, it would not work. I actually do that for our nerve clinics. So I scout the charts 2 weeks beforehand. Honestly, it's more of a filtering process to make sure that things are appropriately being sent to the nerve clinic. And if I can triage it to one of either mine or David's private clinics or not, non-nerve clinic, general hand surgery clinics, I'll send it that way just to make sure that those patients are appropriate for that particular clinic. So I think that's one thing you can do. I think if I was starting in practice now, I would spend some of that time developing patient education materials about how your particular workflows. So it could be a lot of things like common post-op questions or what the course would be like for a common surgery. I'm trying to do some of that now, just because I know kind of how I do things. The struggle with that is that you may not know how you do things early on, like what your process is going to be. But if you are in a practice where it's kind of already set up for you, I think there's probably value in having a patient look at materials that you developed or watch a video that you've done for your particular practice. And it doesn't take a lot to do that. It doesn't have to be perfect. Anything is better than nothing, and it probably will help your support team in terms of heading off some calls.
All well said. And I would agree that you aren't going to have what you do on day one is going to be very different than what you do in year 10. But having a starting point for patient information. And then in 2025, there's obviously a lot of different ways to do that, whether it's a video, whether it's written materials, all relevant and important. And the last thing I would say with your quote unquote free time is it is an opportunity to get out into your community, to meet therapists, to meet athletic trainers, to meet other physicians. That's not so easy today. It used to be you went to the doctor's lounge and hung out, had lunch. No one does that anymore, certainly not in our world. And so you have to be more intentional about those efforts. I would say they're low yield, but they are super important to spend that time. And that's only your time is going to be decreasingly available, and it's really the only time you have a chance to do it.
Yeah, absolutely. And that kind of gets into one of the other things I wanted to mention. They asked about networking and self-marketing, connecting with hand therapists, potential referral sources. I've done the whole go and give a talk at, lunch and learn for a primary care practice. I've done the, give a lunch and learn or like a dinner kind of thing with hand therapists. I found the hand therapists to be super, super helpful. Not because you're going to get patients right away, but you're going to start to develop a reputation that eventually you may be the name that they whisper in the patient's ear if they're having a hard time. And also in our state in Missouri, therapists are now seeing patients, directly. They have that opportunity for a limited amount of, direct care, and then you could refer on after that. So I think that's a great source. Primary care clinic talks is high yield for me, but I do notice that I have a pretty steady stream of PCPs that refer to me, and I try to cultivate that relationship as much as I can. How do you view that? How did you view it starting, and how do you view it now for as you prep new faculty to get into the community here?
Yeah, the more general ones practice, and I've said this before. I think we all should start with a very general practice, even if we have niche preferences, the better. Because if you're going to talk to a primary care practice, a couple of physicians, a couple of APPs, they want to know that you're a one-stop shop for hand and upper extremity is ideal. If I'm going to a bunch of pediatricians and say I deal with congenital upper extremity differences, they will say great. And then 2 years later, when they finally see a kid with a congenital upper extremity difference, they've forgotten who I was. And so that type of work, I think, builds over time in a more granular way, whereas the direct relationships have to be broad. And I agree, super important stuff. And it's not just physician to physician, and don't let anyone tell you it should be. And if your marketing people are dragging you around or your practice, executive is dragging you around, don't just limit it to physicians. There are so many, perhaps even more important referral sources that you have to recognize in the community.
Absolutely. So to go back to one of the earlier questions that's a little more granular, if you have a split OR and clinic day and you have the luxury of choosing, would you rather have clinic in the morning or OR in the morning?
Yeah, I am not a fan of this model. I see the appeal. Split up your day, keeps it fresh. All true, all true. But either way, it's potentially frustrating. because you have to be done with one before you move on to the other. And if you're in the OR all day, as listeners have heard Chris and I say, then you have a chance to get things right timing wise before the end of the day. But if you just have a half day in the OR, if you run behind, you may not be able to catch up. To answer the question, 100% OR first, because otherwise you're following someone else. And if they're not reliable and predictable, it can totally screw you over.
Completely agree. And to add a little bit to this, for the same reasons, and honestly, uh, when I started, I had a half day of research, half day clinic, and I had the choice of choosing which one I wanted that to be. And it happened to be on a Friday. And I knew that if I put the research on Friday afternoon, just if anything after clinic will get sucked up by dictations and charts.
And
So I
energy.
knew that anything will, yeah, exactly, it'll spill over. So as much as people hated my Friday afternoon clinic, including self at times, I knew that it would keep me disciplined if I had the research in the morning and then the clinic in the Friday afternoon. And I would end up shortening the number of patients so I would get my dictations done in time so I wasn't leaving late on a Friday afternoon. And then honestly, patients, and people have heard me say this, but I think patients like Friday clinics because it's still, even in the era of telemedicine and work from home, et cetera, there's something about like, oh, leave work early on a Friday to see the doctor, no big deal, as opposed to leaving in the middle of a Wednesday morning. So I think Friday afternoon has an appeal still, and you kind of talk to patients about it, and they like it. Honestly, support staff don't love it, and I don't love it, but there is some appeal to it. I still see patients on Friday afternoons.
So Friday afternoons are a secret source, and because theoretically Mondays and Tuesdays get you the weekend warriors and people who call in needing to be added on, which is nice. Friday afternoons are never popular. Senior surgeons almost never have Friday afternoon clinics. They are gold, and I totally agree with you. And so, as a young surgeon, if you want to get busy, make yourself available on Friday afternoons. And some places do Saturday morning as well. I'm not here to advocate for working 7 days a week like that, but patients need access at times convenient for them. And Friday afternoon, to your point, can be a really good one.
Yeah, and I agree with what you said earlier. You should have a Monday or Tuesday clinic if you have any choice in that at all. Like as one of your clinics if you have more than one clinic day.
Yeah. The other question was around time slots, which is an interesting question. And it's so personal. We all work at different paces. Chris and I can tell you what we do today. And actually, both of us are doing something a little different with work comp. I'm following Chris's lead a little bit. But my typical time slot is 10 minutes, and it's all comers. And so I do recognize the risk that brings with falling behind if you have one time intensive patient, but 10 minutes, and obviously sometimes there's add-ons, so it's more than one patient every 10 minutes. But in general, I think age gives me privilege in some respects, makes it a little easier to connect with patients and be efficient with those 10 minutes. But again, 10 minutes here, one ends up being 17 minutes, a post-op maybe 3 minutes, and so it ends up working out. And then work comp's a different beast, but we can talk about that separately.
What's been really interesting is that a lot of us are using this Abridge AI app on our phones to help with office dictations, and that's a whole separate conversation too. But honestly, when I hit the button to start and stop, it helps me understand how long I see patients for, and I noticed that I can actually have what I think is a very reasonable history taking, very direct exam, counsel, and be out of the room in less than 5 minutes for some pretty common conditions, which makes me feel better about my 10-minute slots and makes me feel better that you'll figure out which slots you need to double book or you can double book. When you're starting, don't double book your 10-minute slots. And if you choose to have longer slots, you'd rather be running on time than being behind when you start. Now, it's clearly, do as I say, not as I do at this point in my practice, if the fellows ever look at my template. Um, but that also gives you the availability to be available and double book as needed for patients that call and want to be added on. Some other pearls, I would honestly just look at your senior partners slots and how they template it, and then build in some, take some of that stuff, some of those slots away. I always remember that Ryan Calfee would always kind of know the point in the morning in which he would start to fall behind and would leave a couple of empty slots at that point so he could catch up. Now, I don't have that amount of insight, but I don't think you can run very far behind. I'd be interested to see what you think is acceptable amount of which you can run behind. But I remember Rick Wright telling us if you start to run more than 35 minutes behind, patients start to get upset. Patients are kind enough to give us some leeway, but you can't run behind that much that often.
Yeah, if I'm more than 10 or 15 minutes behind, I stress out about it, and it's really hard to catch up. And so I think once you're behind, you typically stay behind unless you get lucky with some post-ops that are quick and easy. Your first point about the ambient listening technology is true. You can really have a great patient interaction in 5 minutes, but I also find that 12, 14-minute discussions are not all that uncommon either. And so you can make it all work. I For new grads, I would say 4 patients an hour is where I would start. I personally strongly believe in one slot fits all. So post-op, new patient, follow-up patient, it gives you much more flexibility. And I know others will disagree with that approach. But as Chris said, it also gives you the ability to add on easily. Every patient is going to be a new patient. And you want to have an incredibly positive interaction so that patient becomes an advocate for you. And so there's lots of reasons to go slow. And maybe that's 3 months, maybe it's a month, and you're sitting there twiddling your thumbs and ready to do more. But I think I would start with every 15 minutes.
So, one question maybe to end here. What do you think is the best general approach to hiring helpful assistants, and perhaps how to, if you have the choice to do that, and how, what are there any particular things you look at in terms of background or questions you ask?
It's an example of things we are not trained to do, but things that are super important to get right. There is no more important decision that you will make to lead to a successful practice than who you have by your side. And I have gotten it right and I have gotten it wrong over my years. I happen to have it right currently. Um, I think we've said this, your nurse, your MA, your athletic trainer, whoever's working with you is your face when you're not there. And for some of us, they're our face when we are there because they can be dynamic and bubbly and really, really interact well with the patients. I think it's a fine line. If you hire someone who's been doing this for 20 years, you're going to get someone very experienced who knows the answer to patient questions, but you're also going to get someone who has develop their own ways of doing things, which may or may not be how you want to do it. And your level of flexibility matters too. So I guess in my perfect world, you want someone with experience, but maybe not 20 years of experience. You want someone who wants to be part of a team, who can see, that my nurse is going to work with Chris's team sometimes, and that part's important. Well, can they play well with others? And will they interact well with patients? Will they take the time to answer patients' questions, to take every patient complaint or call seriously? It's a really tough skill set that nurses and MAs and ATCs have to have. But when you find it, man, it is incredible.
Yeah, I found it to be less the background, but more the person. Because obviously we work with a variety of folks, MAs, ATCs, LPNs, RNs, and that's just even the people just on the hand team. We don't have APPs in terms of PAs or NPs. Sorry, that was a lot of abbreviations. But medical assistants,
OMG.
athletic trainers, licensed practical nurses, registered nurses, physician assistants, and nurse practitioners. OMG. But I think it's the person more than anything else. Clearly, you're going to be getting different clinical training backgrounds, but it's just got to be a person that's good at troubleshooting. Are they good on the phone? Because while that doesn't, we're doing more my chart message, et cetera. If the patient calls and they're distressed, you want somebody who can have the appropriate tone, but also, answer the questions with clinical knowledge, but uh, give the patient a sense of reassurance. And if they're good on the phone, they're going to be good in clinic when they're helping to, that initial rooming process or booking surgeries, et cetera. So I think that's the biggest thing.
Yeah, and the level of insight required for a successful relationship is super important because I want my nurse to know when to elevate something to me, but I don't want everything elevated for me. And when someone's
Mm-hmm.
covering her phones, it gets painful sometimes, and that's fine. I can, if it's just when they're covering, but that level of insight again takes some experience, but it also takes the right person to figure it out. I'm a big believer in sharing the wealth, so to speak, about the literal wealth. And I think doing what we can to make sure that our team is well compensated to the best of our abilities is, I think, really important to a positive relationship.
Yeah, absolutely. And I think the to bring things to a close for at least this episode, it is making sure that there's a shared mission and vision just for your individual, practice. And so if that person understands kind of what you're trying to do and how you want to do things and feels valued, and making people feel valued can take so many different forms. But you got to make them feel valued and part of the team and get feedback and incorporate them into process changes, improvements, et cetera. Because if you don't have that team and you don't have that team that's invested, they're just going to view this as a punch in, punch out kind of job.
Yeah, I think that's well said. And I would add, so for example, when I recently made some changes to my practice, it wasn't just me calling our team leader to say, let's make changes to my schedule. It was, hey, these are my ideas that I said to my nurse. What do you think? What do you recommend? Those kind of small conversations are just important. A, to get it right, and B, to reinforce that we're a partnership, and that philosophy goes a long way.
I did the exact same thing, and I might have even asked for permission to have the conversation. So,
Yeah. The other thing I say, and she hears me say it, it's absolutely true, is the patient will inevitably say, okay, I'd love to do this surgery. When can you do it? I'd say, I have no idea, but I'm going to let you talk to the boss.
is that where I
And
learned that from? Because I use the
maybe
exact same line.
it's a great line and everybody loves it. The patient, I'm sure my nurse loves it. It's true. It's like, it's excellent.
Oh, osmosis is a powerful thing during fellowship. So there are more questions in here we can go through. If you're listening and you have your starting practice or you're starting, changing positions or whatever, and if you have questions that you would like us to address, feel free to do that. I think in the next couple of episodes, we'll probably get back into some more clinical deep dives because I know that's what the folks want. But we're certainly happy to offer whatever advice we can give from our humble perspectives.
Love it. This was fun. And I look forward to next time. Thank you.
All right. Good luck to everybody starting out in fellowship.
Yeah.
Congratulations to those who are finished.
Absolutely. And we want to know your pain points as you get going. Take care.
Yes, please share.